I will hand it over to Robert for the first introduction.
Merci. Well, the discussion, very briefly, the fifth we organized by OESO since the beginning of this difficult period of worldwide lockdown from reason of COVID. But the success of our program has made us realize how important and interesting these virtual contacts at a distance around a clinical case are. Well, in the preceding years, as everyone knows here, OESO has put up monthly cases for discussion, around 70, I think, and each time has been the occasion of a stimulating event. But now, the structure of our discussions has been considerably broadened. Indeed, the OESO-SEMPIRE platform of excellence created with the School of Medicine of Stanford is now in full function and brings together pilot centers from the 5 parts of the world. These centers choose the topics for the discussion, and each time the leader of the center selects a panel of experts to exchange views and questions on the chosen case. And this is in line with the multidisciplinarity which has been the core of OESO since its beginning. The idea had worked well so far, as you know, with discussions organized by the pilot centers of Milan with Luigi Bonavina, Stanford with John Clark and George Triadafilopoulos, from Kenya with Russell White, and from Beijing with Jiho, Mao, and the representatives of 6 pilot centers now existing in China. And this is a very important thing to share together. Stefan Mönning is at the head of the Geneva Pilot Center, where he has developed considerable activity, I know, in esophagology and various diseases in the upper digestive tract. And the session today will be once again a fine, stimulating event with a prestigious panel that Stefan has brought together. But before beginning, let me tell you a little story. Well, I asked Stefan a few weeks ago to structure the presentations following the format of the preceding ones. That is, to begin by giving the gist of the case, followed by introducing the members of the panel. And Stefan Mönning, seemingly, was not really familiar with the word gist. Gist, a word I cannot really define myself very well, but which apparently means the elements which are the essence of something. And well, Stefan very well adapted this new word gist and turned it into gastro, G, intestinal, I, stromal, S, tumor, T. So many among us, I think, in this session will have at least begun already teaching us something which will be the meaning of an English word not very well used. Now I hand it over to you, Stefan. And I hope you understood what I said, but it was a bit funny when I discovered I asked you to put the gist of the case, and you put the gist, gastrointestinal stromal tumor. I didn't know the word very well, the meaning of the word, but I think you didn't either. And this will be at least the first thing we will have learned together today at the beginning of the session.
Yeah. Robert, thank you very much for this nice introduction. And you know, I do mostly what you want. And it is an honor for us in Geneva, for Minoa Jung and me, to have this meeting today. And I have seen that not all the panelists are there, but I will start to introduce Professor Ralf Peterli from Basel University Hospital. He's the president of the Swiss Society Study of Morbid Obesity, SMOB. And he has a very long experience in upper GI surgery in the Clara Hospital, many years. This was the main hospital in Basel for the esophageal surgery. And we are very happy that he can participate at this meeting. I want to introduce Olivier Hubert. He was many years the esophageal surgeon at the University Hospital of Geneva, with a very bright and long experience in esophageal surgery and esophageal diseases. And we have a very good cooperation together here in Geneva. There are other colleagues from Germany. It is Peter Grimminger. He was with me together in Cologne University Hospital with Professor Hölscher. And he is now in the University Hospital of Mainz. And he's doing the highest number of robotic esophageal cancer in Germany. And he is now one of the leading surgeons for this robotic esophagectomy in Europe. And I'm very happy that he will participate. And Beat Müller from the University Hospital of Heidelberg, he is specialized for bariatric surgery and for upper GI surgery. And Johannes Zachal from Vienna, he was many years in the Billroth University, responsible for the esophageal surgery. And now he is the lead of the St. Joseph's Krankenhaus in Vienna, and his specialty is upper GI surgery. And Minoa Jung, she is my co-worker here in Geneva. She was 1.5 year fellowship in the Yonsei University with Professor Yang, and Professor Yang is one of the leading robotic surgeons in the world, and so she has a very bright experience in bariatric and in oncologic robotic surgery. And Markus Möhler, he is a good friend from Germany. He is the chief of the S3 guidelines, gastric cancer in Germany, and he is gastroenterologist and oncologist. And Rupert Langer, Rupert Langer is pathologist. He was many years in Bern, and he is now the director of the Pathological Institute in the University Hospital of Linz in Austria, and a long friend in our OESO family. So I want to start with my talk, and yes, we have selected GIST because of everyone is talking about esophageal cancer, but I think it is important to talk about benign diseases because of they are rare, but if you look to the different types of benign tumors, in the centers we have every year some cases. That's it? Okay. So if you are looking for the epidemiology, so you can say that gastrointestinal stroma tumors are the most common mesenchymal tumors of the gastrointestinal tract, and for the most part occur in the stomach, more than 60%, and in the small intestine, 20%. Esophageal gastrointestinal stroma tumors are extremely uncommon, accounting for less than 1% of all GISTs. And as with most rare pathologies, many questions remain unanswered regarding their optimal management. And it starts with the diagnostic. It's clear every tumor of the esophagus, the most important diagnostic tool is an endoscopy. And because of it's a submucosal tumor, you need an echo endoscopy. And the question is, should we do a fine needle biopsy or not? Is this necessary? if you want to enucleate the tumor after that, probably it's a problem. And I think we should discuss this later. CT scan, it's very clear this is absolute necessary, and we have to discuss which role has the PET scan. And if you look to the literature, there was a very important paper from Christophe Mariette and the French group. And this paper was published in 2015 in Annals of Surgery. And here was the question, what is to do with this GIST? Is there open or minimal invasive surgery possible? You know that the guidelines in the US said for gastric GIST long time, because of the risk of rupture, there is no indication for laparoscopic surgery. But in this series with more than 280 laparoscopic cases and 380 open cases for gastric GIST, it could be shown very clearly that there is an advantage in short-term outcomes without any compromising oncological results. We have this data not for the esophageal GIST, but if you look to the literature, there is the question, should we do an enucleation, or is an esophagectomy absolute necessary for these tumors? And I want to present you a small video. This is a case I operated 4 years ago, and I can say the patient is now in a very good shape. You can see here the thoracoscopic approach. This is the preparation of the esophagus. Here the vena azygos, and the GIST is above the vena azygos, visible. And we are cutting in the next step the vena azygos.
Excuse me, we don't.
Stefan, we can see the video.
Cannot see the video.
You cannot see the video. Ah, okay.
There is a title, but another title.
You have to close. Right.
Yeah, great. It's working.
Is now working?
Yes.
Now there is a title, it works, but not the video yet.
So, Mikael?
Yeah, it's okay. The video is working. It's okay. Yeah. Yeah, it's okay.
So, but I cannot see it. Ah, yes. So it's an enucleation of the GIST intrathoracic. We have resected the vena azygos, and then we have enucleated the GIST, and at the end we have done an endoscopy to see that there is no problem with the mucosa, and at the end we have done 3 stitches for the muscle layer, and the result was very good. There were no problems, and swallowing was good, and it was a GIST without mutations, a very low mutational mitotic activity. So there was not necessary an adjuvant treatment. So we go back to the okay. So about this question, what is the best surgical treatment? Christophe Mariette and his group have published in 2015 a paper, and they could show that if the tumor is not too big and if the tumor is not aggressive, for these cases an enucleation is absolutely enough, and there is no need for esophageal resection. If the tumors are bigger, it has to be discussed to do esophageal resection. And this is another paper published in 2017 in Diseases of the Esophagus, and they compared the same subject, and tumor size and mitotic rate of the tumor are associated with pure survival, and this is important for the decision to do an enucleation or to do esophageal resection. And this is another paper published in 2018, and it could show that thoracoscopic enucleation of GIST seems to represent a valuable option because of the morbidity is lower than in open surgery and the oncological outcome is the same. And the question is, if you have a very giant esophageal GIST, and we know this from the gastric GIST, to reduce the extension of the surgery, probably to do a neoadjuvant treatment. This treatment, we have the Apollon trial from Germany, and so the treatment is you start with Glivec, and after 1 month you are doing a PET scan, and if there is a significant reduction of the tumor, you go on with the Glivec, and after 3 months again a PET scan, and the point when the tumor is not more shrinking is the point for surgery. The conclusion is, for the moment, esophageal GIST is rare. This is very clear. Important things are tumor size and mitotic rate. And there is no contraindication for minimal invasive surgery. And if the tumors are bigger than 5 centimeters, you have to think about resection, surgical resection. Enucleation is probably difficult. And neoadjuvant treatment is an option to bring these patients in a status where you can do an enucleation. So thank you very much for this moment. And now Dr. Murat Begovic will present our case. So Murat is doing it.
Yes.
Hello, Murat.
Hi.
I'm Mirza.
Thank you, Professor Monique, to give me the opportunity to share with you this very interesting case of a 73 years old female who in the past have 2 success treatment of 2 cancers, one of the breast and the other from the thyroid. And she presented to our consultation with the 2 months of severe dysphagia and spasm after ingestion of a liquid. She didn't present any gastroesophageal reflux. So she saw a gastroenterologist who have done an upper gastrointestinal endoscopy. And then we sent her, I will show you some pictures. Then we sent her to endoscopic ultrasound with the biopsies. And I will show you now. So the upper gastrointestinal endoscopy saw at around 40 centimeters of upper lower dental arch, this huge tumor, submucosal, which was responsible of the stenosis at this part of the esophagus. So that's some views of the tumor. And what we saw too is there is a part where is an ulceration of mucosa. So after that, the endoscopic ultrasound show this tumor, submucosal, which was sized 6.5 centimeter. And the fine needle biopsies showed this without any coloration, but after markers coloration of DOG1 and CD117, it was positive, and the diagnostic of gastrointestinal stromal tumor was done. After that, we do some thoracoabdominal computed tomography, which showed 7 centimeter size tumor of distal esophagus, and we complete with the PET CT, which doesn't show any metastases. So I will show you some video. I hope it works well. So for the thoracoabdominal computed tomography in 2 views. So as you can see here in this distal part of the esophagus is a huge tumor. Now for the PET CT, just to see, it's this huge tumor capturing the marker, and in the other view. So what we have done after that is we present the case of our patient to our tumor board meeting, and the decision of the panel was to do a subtotal esophagectomy by hybrid approach. That's what we have done, and I show you some videos of this procedure, the Ivor-Lewis procedure. And we split it in 2 parts, one for the total laparoscopic gastrolysis with suprapancreatic and celiac trunk lymphadenectomy with the jejunostomy, and the second part is the right thoracotomy with subtotal esophagectomy and end-to-size circularized staplet anastomosis above the vena azygos. So here is the video. For the abdominal part, first we cut the gastrocolic ligaments, and that allowed us to release the great curvature of the stomach, but also to go retrogastric and to release completely the stomach. We see here just before that was a huge splenic artery. We do also lymphadenectomy in the area of suprapancreatic and celiac trunk. And here we finish with the cutting of the left gastric artery. And then we go to the thoracic part. So through the right thoracotomy, we first we remark this huge tumor here, the GIST, and we release distal part of the esophagus to make a tour around and to mobilize it easy before we cut the proximal part, as we can see here. And after that, we prepare for the anastomosis with a circular stapler. We put the head of the circular stapler in the esophagus, and we do end-to-side gastroesophageal anastomosis above the vena azygos, and we over-sutured this anastomosis like here. So that's how it looks like after the removing of this huge GIST tumor. And patient present any complication during his hospitalization and 30 days after. So at the first postoperative day, we let all our patients to drink, but at the 5th day, we do some transit of the contrast in esophagus, and we see that there is no leakage or a stenosis in the anastomosis. So after that, we can give patient to eat, and there was no any pylorus stenosis. So the histopathological analysis show us that it was a low-grade stromal gastrointestinal tumor of 6.5 centimeter, PT3 and 0, and with a low mitotic index, and there was no activating genes mutation. Here's some picture from this from our histopathologist. So as we can see from the mucosal view of this huge tumor, here is a transected tumor and histological part of the tumor with a huge cellularity. We present one more time our patient to the postoperative tumor board meeting, and due to the low mitotic index and also the absence of any mutation, there was no indication to do the adjuvant therapy. We saw recently our patient 1 year after for the first follow-up, and in this case, there was no clinical or radiological sign of recurrence. And that's all for me. Thank you very much for your attention.
Yeah, Mirza, thank you very much for the presentation of the case. I had just now a telephone call with Peter Grimminger. He has problems to participate, technical problems. Probably it is possible that Beat Langer is that Beat Müller is doing leading the discussion, make the moderation.
Hello, everybody. Can you hear me? Hello?
We can hear you, but a bit far away, Beat.
Ah, thank you. So
maybe you can put your mic close to your mouth. Will help probably.
To be honest, I'm the first time within this round, so hopefully I'm doing correctly when I do the moderation of the discussion. I think everybody of the panel and also of the audience can participate. Are there any questions to the referent?
Yeah, we have a question from Reda. Reda, do you want to intervene?
Yes, I'm Professor Dr. Reda from Egypt. My question is concerning the open thoracoscopy. Is it depending on the size of the tumor, or why we don't proceed for thoracoscopic or totally mini invasive?
Yeah, so it's a important question because of our experience with hybrid esophagectomy is excellent. You know, I was more than 20 years in Cologne, and there we had the biggest European center for esophageal surgery with 200 cases per year, and we had with the hybrid technique excellent results. Especially the anastomotic leakage rate is much lower with this technique than in the minimal invasive. If you look to the results of different reviews to this subject, there is a anastomotic leakage rate in thoracoscopic esophagectomy around about 15%. And we had in Cologne an anastomotic leakage rate with the hybrid esophagectomy 5%. And I'm in Geneva since 2016, and we have now nearly 100 cases. And I had 2 anastomotic leakages in this time. So this is the reason why I do the hybrid technique. And yeah.
What about the respiratory complication?
What?
Respiratory complication.
Yeah, they are a little bit higher, but you know, with the peridural catheter, it is not a real problem. And we have done in Cologne more than 800 cases with hybrid.
Okay, thank you. Thank you,
But
sir.
I think this is an interesting discussion, but it's more a discussion on minimally invasive versus open or hybrid vasectomy. And Stefan, I think this is a question of expertise also,
Yes.
not only a question of the technique. So the total minimally invasive technique is a little bit younger than the hybrid
Correct.
technique, and the hybrid technique takes the best from the open, or the most difficult step is done by open means. And I'm convinced that we will be able in the near future to do the same as you do in hybrid. But the other question is if we have an additional benefit comparing hybrid to totally minimally invasive. But this is the answer we will receive in the future, I think.
Yeah.
There is no direct comparison so far.
So I agree totally. And you know, Peter Grimminger, he's not. I hope he's coming to our discussion. He's doing it robotic, and he's doing the anastomosis with the same technique as in the open procedure, with the oversuturing and all that, and could reduce the anastomotic leakage. I think it is possible to do that, but for that you need the number of cases. And you know, in Switzerland we have totally, I think, 400 cases in the whole country. So it is different, and for the moment, hybrid is for me more safe, and this is the reason why I'm doing that.
We do the same technique as Peter Grimminger, and we have very good results since we are doing this technique by robotic assistance. And I know it from other centers in Germany. So it seems that this is the German way of doing minimally invasive
anastomosis. Yeah.
We have a comment from Denis.
Yes, thank you. In Bordeaux, we have developed a technique of thoracoscopic access in the left lateral position, and the dissection of the esophagus is achieved by thoracoscopy. And at the end of the procedure, I do a very narrow axillary thoracotomy, 8-10 centimeters, and the anastomosis is performed by separate stitches at the top of the thorax, exactly in the same way as in open surgery, but in very much more comfortable condition, because when you do it by a large thoracotomy, frequently the anastomosis at the top of the thorax is very high and very far from the operating site and maybe uncomfortable. In that situation, in our technique, the anastomosis is performed at the top of the thorax, and we have a direct view on the anastomosis while we are performing it. It is a hybrid thoracoscopy, but our leakage rate is exactly the same than we had the same before this technique. By an open approach, it's around 4 to 6%, because it's exactly the same technique, and so far we are very satisfied with this technique.
So I think there are several ways to do the thoracic part, and we will learn in the future which one is the best. So there are several ways to reach Roma, I think. Are there other questions to the case?
So Peter Grimminger is now there.
Perfect.
Sorry, it took a while to get through the French process of logging in.
But normally you are German and you are at time. What's going on in Mainz?
We're blocked from the website, but I figured it out.
It's perfect that you are here. You can do the moderation. I already defended your technique.
Very good.
For totally minimally invasive vasectomy.
It's good that I have friends.
One.
Okay, let's get on.
Is there anyone who has experience with neoadjuvant treatment for this GIST? Is there any?
I see Ralph raising the hand.
Yes, thank you for this nice presentation of this case. I was wondering, may I have missed it? You did not do any neoadjuvant treatment? Because I mean, for downsizing, and maybe even be able to do a trans-hiatal approach with a robot or whatever. But maybe if it gets small, then you can go on with a smaller operation.
Ralph, the problem was that there was no mutation.
Mm-hmm.
So the GLIVEC doesn't work. It is...
I think with the wild type, there's no chance of doing a neoadjuvant chemotherapy right now at this stage.
Stefan, I have one question, another question. In your slide, you showed that in some cases you could perform an enucleation of the tumor without esophagectomy. In this very particular case, you showed that you decided to do an esophagectomy. Then, what are your absolute criteria to choose either an enucleation or an esophagectomy? Is it the size of the pedicle of the tumor on the esophagus, or something like that, or something else?
So I've showed you two cases. The first case, this was a round gist with a small pedicle. And this was ideal for enucleation, and there was no question to do it. But the second case, it was not only that the case is 7 centimeters. I think this is not the most important thing. If you have looked to the endoscopy, there were ulcerations. And if you have seen the pathology specimen at the end, it was really not this smooth areal between submucosa and mucosa. And this was the reason why I said, no, this is too risky to make an enucleation. So the experience we had in Cologne, we had 20 cases in all the years. And in Geneva, we have now 3 cases. There is no really experience. For the round, small esophageal gist, I think thoracoscopic or laparoscopic, it belongs to the localization. Enucleation is the standard way to do it. But in some cases, it's necessary to do an esophagectomy.
I totally agree with you that in this case it was not possible to do an enucleation. But in a smaller tumor with a small pedicle, what is your limit to decide either esophagectomy or enucleation?
This is a difficult question. So if you look to the paper of Christoph Mariette, then it's 5 centimeters, but it's tumors of 8-9 centimeters, I think. And when you cannot do a neoadjuvant treatment, then I would do an esophagectomy. But if there is a possibility for neoadjuvant treatment, I would do that. And probably then it's possible to make an enucleation. I have a question to Rupert Langer.
Yes, I have also some questions.
Ah, that's good. Rupert, do you have seen many cases in the
No. Usually, as you already mentioned, the mesenchymal tumors in the esophagus are leiomyomas and not just. So from time to so I think I have seen 1 or 2, but not as many and not in that size. And I could imagine when I saw the macroscopic image how the consistency of this tumor had been, and I think it's supposed to be very fragile. You have these hemorrhagic leaks everywhere, so I could imagine that if you would try an enucleation, this would not have been a good idea. But I was also wondering, what is your criteria? Can you estimate also the density of the tissue by endoscopic ultrasound, for example, where you may see these hemorrhagic areas, and you say, oh, maybe there's necrosis, maybe it's not it's not firm enough to do an enucleation. But I think it should also correspond then somehow to size, because the smaller tumors, maybe you would not even consider to remove them. But these, yeah, I think 5 centimeters should be quite okay. Yeah. And are you always doing biopsy before, or I think you mentioned fine needle biopsy and the problem with
Yes.
later endoscopic removal, because I think it matters whether you have a leiomyoma or if you have a GIST, in particular with that size.
I agree. And I remember many cases we doesn't want to have a fine needle biopsy because of the differential diagnosis is leiomyoma, and if a leiomyoma makes dysphagia, we have to do something. And if it is a GIST, it's the same. So I think in this case, it was because of, it was a big case because of this ulceration, and there was a suspicion probably it is not a GIST, it is something malignant. And this was the reason why we agree with the fine needle biopsy. But we can ask the others what is their experience. What, Ralf, what you are doing in Basel? Would you do a punction, or would you say it must be out, so we go?
No, personally, I have to admit that we don't have experience with esophageal GIST, but we want to know what it is. And in the gastric region, we definitely want to know. But it's not a needle biopsy. Probably usually is not a sufficiently tissue.
Dennis, what is your experience? Would you do in esophageal GIST or the same in gastric submucosal tumor? Would you have a biopsy or a?
I think that it is very important to have a preoperative diagnosis and to do fine needle biopsy, even if it's not a very accurate diagnosis, because the fine needle biopsy does not provide a lot of material, and sometimes for the pathologist it may be difficult to decide whether or not it is a GIST. But leiomyoma can be always removed by tumorectomy, by enucleation.
Yeah.
Therefore, it is absolutely, for me, it is mandatory to have a preoperative diagnosis. And if there is a doubt of a GIST, we will do the esophagectomy or enucleation according to the size of the tumor. But whenever it is a leiomyoma, it is always an enucleation.
But for diagnosis, I think if you want to know is it a GIST or is it a leiomyoma, then we can do it in a very little tissue, even in cytology specimen, because we just would need one or two immunohistochemical stains for the diagnosis. Of course, we cannot count mitosis and estimate high risk, low risk basing on mitosis, but this also somehow corresponds to size. And I think for the diagnosis, GIST versus leiomyoma or schwannoma, for example, because this tumor also had some very spindly areas, we don't need that much tissue. And we would not, I think, not do molecular analysis up front unless the rare case that you would go for neoadjuvant treatment. But I think this is a very rare scenario of a very rare tumor, right?
Absolutely.
A comment on the chat from Maria saying she participated in a multi-institutional pathology study that included 53 esophageal GIST, and she's showing that the progression risk was greater with above 5 centimeter and higher mitotic rate.
I think it's helpful in bigger tumors. So we need it especially in bigger tumors, because leiomyomas we always enucleate, even though they are when they are 8 centimeter. And for instance, we had one 2 weeks ago which was 8 centimeter, and the discussion was to resect the esophagus, and the puncture helped us to differentiate between GIST and leiomyoma. So we did an enucleation, and the patient did fine. It was at home 3 days later.
I think also the enucleation for the leiomyoma, and normally it's nearly always possible. It's not dependent to the size. On GIST, I think the size does matter because the pathogenomic factors go up. In leiomyoma, I think it does not matter how big it is. It will not change the pathology. It's more symptomatic maybe, but it's normally possible also to do it minimal or robotically, minimally or robotically for enucleation. But on GIST, I think the size is one big factor, and therefore the combination of symptom size has to actually lead your treatment strategy maybe on this.
Yeah. And I think you really have to consider leiomyoma is a benign tumor, and GIST has like a range of the possibility of malignancy or progression, metastatic rate. So I think to consider it as a potentially malignant lesion from the beginning, and until you have really all the information, the risk estimation, as Maria just told us, more than 5 centimeters high mitotic range. This is a completely different scenario, and leiomyomas have always a very firm cutting surface. So I think it's a solid, very dense tumor, and just usually doesn't have that stromal component or that firm component, and in many cases it's quite fragile. So to know, is it a leiomyoma or just I think if it's reaches a certain size is really important, but we cannot estimate the mitotic count on a small biopsy sufficiently. Okay, if we see on that biopsy already like 10 mitosis and then a very like sarcomatose appearance, then probably we say, oh wow, it's high risk. But usually we are very cautious about yeah, maybe we give the number, but yeah, we say okay, it's a biopsy and it has to be like counted on the whole resection specimen. But the size you will know from your imaging.
But thank you, and I think we can now make a small summary. We have seen important is the diagnostic with the echoendoscopy, and I think fine needle biopsy is useful, even because of the pathologist can make the differentiation, GIST or not GIST. And surgery, it is, if possible, an enucleation. And for the very big one, GIST with the ulcerations, it's in some cases necessary to go for surgery. And this is minimal invasive surgery, hybrid or not hybrid. This is the question of the team. And neoadjuvant treatment could be an option in very enlarged GIST. We know that from gastric GISTs. So I would like now to change to a second area, and this is about obesity surgery, but not only obesity surgery, it means obesity surgery and oncology. And Ralf Peterli will make the moderation, and he will start with an interesting paper about Barrett esophagus and reflux esophagitis 5 years after laparoscopic sleeve gastrectomy and Roux-Grec gastric bypass. Ralf.
Thank you very much for the opportunity to present these data and afterwards moderate the case. Can I get my screen? Voila.
Yeah, you should be able to share your screen now.
Now, which one is it? Okay. All right. So this is the work we've done at our institution at University Hospital of Zurich, together with Klinikum Bayreuth. Apparently, Professor Fiet is an expert on Barrett histology as a pathologist, research department. And when we see at the increase in numbers of interventions being performed in bariatric surgery, almost 1 million per year, we see an increase of sleeve gastrectomies, and which is worrisome to a certain extent because we know about the issue of the reflux. So if we look at comparison of reflux, from bypass to sleeve, in terms of GERD symptoms, we can see that gastric bypass is more efficient in remission of GERD, and that sleeve gastrectomy has a higher de novo development of GERD. But we also see in about 10% of the gastric bypass patients that they have GERD symptoms 5 years after the operation. And there have been some series demonstrating a very high rate of Barrett esophagus 5 years after sleeve. Especially the Genko paper in 2017 showed a 70% cumulative incidence of Barrett in a cohort of about 100 patients, and most of them, they did not even have symptoms. So it's not the symptoms that will guide you to make an endoscopy and find out about Barrett. And another group found even 19% Barrett after sleeve. So nobody's really shown much about de novo Barrett in bypass surgery. If you look at this large database from New York State on the follow-up of bariatric procedures, about almost 50,000 cases that were followed almost 10 years, they could show that the cumulative incidence of Barrett's was depending on the intervention type. So gastric bannings, sleeve had higher rates of Barrett's and gastric bypass. But this did not show progression into esophageal adenocarcinoma. That was not dependent on the surgery type, but I mean there the numbers are much lower with an incidence of 0.4% per mil, excuse me. So we had designed our cohort to analyze the cumulative incidence of Barrett esophagus 5 years down the road, comparing sleeve and bypasses in 2 centers, and in Zurich. Some secondary endpoints were the prevalence and severity of reflux esophagitis, use of proton pump inhibitors, and prevalence of dysphagia or reflux symptoms. And in a subgroup of patients, we also looked at pH monitoring. Excuse me, somehow there's an automatic change of slides integrated here. So we also looked at manometry and Bravo capsule pH metry. The study design was an observational study at 2 centers with at least 5 years of follow-up. Patients with primary interventions were included, and we excluded patients that within this period needed conversion from sleeve to bypass or another BPDDS. So these patients that needed conversion into bypass due to GERD did not have Barrett. So we did gastroscopy with biopsies. We used a Prague classification for Barrett, and we did do the LA classification for esophagitis, and we used a number of questionnaires, and as I said, in the subgroup, we used the Bravo capsule and manometry investigation. So before surgery, the patients with the sleeve were heavier, which is sometimes an indication issue, but we if you especially want to do a staged concept with primary sleeve followed by another operation, so there was a difference in there. And more of this, the GERD patients received a bypass, highlighted in blue here, where the difference was significant. And more patients had hiatal hernia in the bypass group, but the ones that had one in the sleeve group, they received simultaneous hiatal hernia repair. And we already have one Barrett in the bypass group. Following surgery, 7 years down the road, the BMI reduction was more pronounced in the bypass group, so weight loss was better. And also there was a small difference about the follow-up rate, the follow-up time between the two groups. So the GERD symptoms were more often prevalent or existing in the sleeve group, which is not a surprise. The rate of patients needing PPIs was higher. Hiatal hernias that developed during this time was higher. And also the rate of patients that had reflux esophagitis was significantly higher, but if they had a reflux esophagitis, grade A was more often seen in the bypass group compared to the sleeve group that had higher levels of esophagitis. Overall, we saw 3.6% of Barrett in the sleeve group and 2.3% Barrett's in the bypass group, but just only counting the de novo Barrett's, it was a small difference between 3.6 to 1.2% of the bypass. If you looked at the pH-metry, there was significantly more acid reflux, also acid reflux episode, non-acidic reflux episodes, and the symptom association index was clearly saying that this is acidic reflux that the sleeve patients suffered from. If you looked at the questionnaires, I'm not personally so familiar with these questionnaires, but the GERD-Q questionnaire about heartburn and regurgitation, sleep disturbances, and medication use, epigastric pain and nausea, the average points were significantly higher in the sleeve patients and also, also in the patients that did reach the threshold, the number were higher. And if you looked at the Leuven postprandial distress scale, also taking some symptoms into account, you saw more people in this bypass group that did not suffer from severe symptoms. So the more severe symptoms were in the sleeve group. So sleeve gastrectomy not only causes reflux, but it also causes symptomatic reflux and symptoms that are linked to also functional problems of the upper GI tract. So in summary, at least 5 years, and in our cohort, it was an average of 7 years after surgery in 83 sleeves and 86 bypasses. De novo Barrett was seen in 3.5% of sleeve patients and 1.2% in the bypass patients. Obviously, we were underpowered that this difference could have reached significance. And the sleeve does have more often reflux esophagitis and also more severe reflux esophagitis, more hiatal hernias, more use of PPIs, and more GERD or dyspeptic symptoms, and also more pathological pH-metry. But we have to take into account that we did take out the patients that did have a revision in the meantime. So these were 11.4%, but none of them had a Barrett. So these are real numbers of 2 centers. And the question that we can discuss now first is, why do we have these discrepancies between the studies? We looked at these papers and it was not clear for us whether we have to deal with just blind biopsies, random biopsies, or if you, for a Barrett diagnosis, you know that better than me, that you have to have a visual change of the aspect of the esophagus and then take biopsies out of these regions. And this is the definition of Barrett. We don't know whether these other trials that have these high levels or high numbers of Barrett's did it differently. It's not mentioned in the papers. And then the next question that I'm very interested from you to know, when do we have to do the first endoscopic follow-up, as symptoms are not the leading, doesn't help us easily to define patients at higher risk to do the endoscopy. So we now think it may be 5 years, and then depending on what we find, then we have to do a surveillance program, especially if you find Barrett's. So I would like to open this paper for discussion. Maybe we have some time before we go to the next case. Is that correct, or do we just direct it? We discuss it at the end, Mino. Is that correct?
I think it would be good to ask the questions right now in regards of your paper. We can absolutely do that. I think that would be good.
Okay.
Yeah, that's a good idea.
Who would like to intervene? I know, Denis, you are pretty familiar with the topic.
Beat, what do you think? You have to open the microphone.
In principle, I agree with almost all what Ralph said. It's a wonderful survey on the problem of GERD after sleeve gastrectomy. And I think we do endoscopy after 3 to 5 years to see if there is a Barrett or a reflux problem, and then we do a surveillance program. What I'm not sure is if this is really a killer criteria against sleeve gastrectomy, because there are other problems which would have to be addressed when we compare sleeve to bypass and other bariatric procedures. But in terms of reflux, all is true what has been said. And I'm a little bit surprised and also relaxed that you only found 3.5% of new Barrett after 5 years. We know other results from other groups, and I think this is a kind of bias which we have in most of the retrospective studies, and most of the studies we know about these problems are retrospective.
Thank you, Bea, but I think it's not only the case of retrospective. I don't think in this, to find cumulative incidence, I don't think this is such an issue. But the question is, the first thing is, we also have it after bypass, so it's not a matter between sleeve or bypass, it's just everything we do up there. I mean, these patients have if somebody has GERD symptoms before he gets into bariatric surgery, has a higher risk of developing Barrett. That was shown in this large trial of the New York State database. But it's also after bypass. So if bypass patients are asymptomatic, maybe at 10 years down the road, it's worthwhile to perform a gastroscopy in these patients as well. And it's not, I mean, both operations have pros and cons. That was not the issue. But of the pathologist, I mean, these series with higher prevalences, what is the definition? How can this differ? Does anybody have an idea why this difference is so large? It's not just retrospective approach.
We have Reda who wants to intervene as well.
Yes. My question is, my explanation about the difference in incidence of reflux or Barrett after sleeve or bypass. It depends on the surgeon, because we know all surgeons are doing sleeve, but not all of them are doing the same technique. We don't have until now a standardization of the technique. So some people go to deeply dissect posteriorly. Some patients go to make
Now I can't hear you anymore. Sorry, Reda.
Very narrow tube, and of course,
you don't have the microphone turned on. Excuse me, Reda. But I mean, what he said about standardization, I mean, this is true. Do you really open the hiatus if you don't? But still, pretty much it has been standardized in the last couple of years. So I don't think that really explains the difference. The Italians that do the operation I've seen, it looks pretty similar to what we do. So I don't think it is that so important, but maybe it's an issue. Minoa, do you want to go to your case? Or is there another
Denis,
question?
I think
yes, Denis.
A question from Denis.
Go ahead.
Yes, yeah, may I? Yes, I think that we have to give a very strong recommendation to the bariatric surgeons and to recommend strongly that all the patients operated by a bariatric procedure, and especially after a sleeve gastrectomy, should absolutely be followed by regular endoscopy all along the timeline. And we know that the risk of Barrett esophagus increase along the time. Therefore, systematic endoscopy should absolutely be performed all the time in the patient. In this patient, and we don't know exactly how frequent. Every 3, 4, or 5 years, we do not know. But bariatric surgeons should be absolutely aware of it.
I fully agree. The problem is many people in the world don't even do an endoscopy prior to surgery, neither do they do any manometric examinations, which I think are crucial to find out contraindication for that surgery. So, but I fully agree that we have to have, but it's not defined yet at what time, the first time it has to happen. I think we have to have more studies to find out about that. Thank you very much. And Minoa, you think you want to go on with your case?
Okay. Yes, thank you very much, Ralph, for this nice presentation and for having accepted our invitation. And I also thank Stefan Mönig, my colleague and senior, for having me presenting my bariatric case. I will get on the presentation mode, I hope. Can you see the presentation right now?
Yes, we can. If you can switch mode, that would be better.
Yeah. I always have this with these several. Maybe like this. Is it okay?
Yeah, great.
Yeah. So I want to present a patient who works at our hospital, actually, who came with severe obesity, a BMI between 35 and 40, who had a long history of gastroesophageal reflux, and also in the endoscopy, some pathology. So it's a 48-year-old patient who works at our hospital, who went to a first bariatric consultation almost 1 year ago in a private practice for this BMI of 38.4. And he filled all the Swiss conditions to get access to bariatric surgery with a 2-year diet program and with a BMI above 35. And he even had some comorbidities. He was of Spanish origin, by the way. He had an arterial hypertension, as I said, gastroesophageal reflux disease, and the obstructive sleep apnea, which was treated. And he also had some depressive disorder. He had a gastroscopy 4 years ago where they did find a Helicobacter pylori infection, which was eradicated back in that time, and also a small hiatal hernia. He then got a gastroscopy also in private practice in Geneva, which found this lesion at the incisura angularis, with at the closer close-up, which was suspect for metaplasia and which got a biopsy according to the protocol, where they do several biopsies of the lesser and greater curvature at the antrum level and also at the corpus level, as well as at the fundus level and as of the incisura, because it's a common place for metaplasia. They described a small superficial lesion above the Z line and about a 20 millimeter lesion at the incisura of the angulus. And they did classify this Paris classification according 2A up to 2B for this more or less flat elevation and no erosion of this lesion. The biopsy was done, as I said, according to the Sydney protocol of all these localizations, and the diagnosis of the pathology found in a metaplasia, an intestinal metaplasia of the antrum at the level of the incisura, no Helicobacter pylori this time, and it was classified as Olgim 1, and there was also a moderate esophagitis without any signs of Barrett. So the pathology found this esophagitis, otherwise a gastropathy of the stomach, and this intestinal metaplasia without dysplasia of a moderate intensity or even a light intensity of this metaplasia. The proposition of the surgeon in the private practice was in that moment to do a standard proximal root gastric bypass. The gastroenterologists of the same private practice did suggest not to get the performance of the gastric bypass, but to do an ESD first. And it was the gastroenterologists actually of the private practice who cancelled the intervention and who did the ESD first. The patient then got the ESD at the university hospital, which confirmed the mild intestinal metaplasia at the antrum level. And the patient who works at the university hospital then decided to really cancel the operation and to come to see us to discuss for further decisions. As we heard before, the sleeve gastrectomy is usually not so much indicated in case of gastroesophageal reflux. The patient does not have a Barrett, which would be an absolute contraindication for the sleeve gastrectomy, but we don't suggest the sleeve because of this idea that the sleeve gastrectomy will increase in many cases the GERD, because the lower esophageal sphincter can be weakened after the dissection of the angle of His. The cardial dilatation, which sometimes can occur, which also increases the reflux, and the increased gastric pressure because of the decreased compliance of the gastric wall, which may be the reason for this increase. So sleeve was not an option for us. There are many papers discussing the problem of reflux after sleeve gastrectomy. Here I only listed papers who did not only look at symptoms, but also did gastroscopy or pH metries. And many of them found the GERD after the sleeve gastrectomy. Some of them also found the Barrett at the long-term follow-up after sleeve gastrectomy. The second question, if we should do a standard gastric bypass, this is also a tricky question. We looked into the guidelines, into the European guidelines of the gastrointestinal endoscopy in regards of the intestinal metaplasia. The gastroscopy is absolutely necessary, also with the research of Helicobacter pylori, which has to be eradicated before any surgery. And it is this chorea cascade which goes from the normal mucosa to the intestinal metaplasia, which is a precancerous lesion to the dysplasia and carcinoma sequence as a theory behind. And this atrophic gastritis and intestinal metaplasia are considered as gastric precancerous conditions, especially if the intestinal metaplasia is concerning not only the antrum, but the antrum and the corpus. The risk seems to increase for later gastric adenocarcinoma with different numbers in the literature, up to 10% in the cumulative incidence after 5 years. The risk stratification is also done in regards of the severity of the intestinal metaplasia, and the severity starting from 3 and 4 is really increasing the odds ratio. Also, the incomplete intestinal metaplasia is at higher risk for gastric cancer, and also the extensive lesion, which doesn't only concern the antrum but also the corpus, is increasing the risk, as well as the family history. So the guideline, which is published by the ESG guideline, is talking about the intestinal metaplasia, which is only in the antrum or only in the corpus, which would be the case in our patient. If it's only this and no family history, no incomplete intestinal metaplasia, a surveillance would not even be recommended. So our patient who had a Helicobacter pylori infection, but which was eradicated and which is no longer present, is really in between surveillance and no surveillance. So we then decided to go safe, and we did a robotic gastric bypass with resection of the excluded stomach. So we started, it's not an oncologic resection, so we go close to the greater curvature of the stomach, and we mobilize the gastrocolic ligament here already up at the His angle, and we complete the dissection in the infrapyloric region, which would normally be the station 6 in oncologic surgery. Here we are going, of course, a little bit higher, not at the level of the pancreas head. You can see the section of the gastroepiploic vein, the right gastroepiploic vein, and here we have the right gastroepiploic artery, which is dissected with the harmonic and clipped, and afterwards sectioned by the harmonic device. We put a gauze on the head of the pancreas to protect the pancreas, which will be removed after the suprapyloric dissection. And then the transection is done of the duodenum, about 2 centimeters distal of the pylorus. The lesser curvature is easier to dissect because we would conserve the left gastric artery to conserve the vascularization of the future gastric pouch of the bypass. And then the lesser curvature is dissected above the angle to prepare for the stapling device to create the neopouch for the gastric bypass, which you can see up here. And this is the remnant stomach, which was fully mobilized and which is removed by a big endobag and a small incision at the end of the operation at the just below the umbilicus. And we do the reconstruction now just as a standard gastric bypass with first the gastrojejunal anastomosis. You can see we have some bleeding. I had here some bleeding of one of the branches of the left gastric artery. And we do this, we start this with the posterior wall with a running suture on the posterior wall. It's a Vicryl 2.0, which is easier with the robot not to destroy the stitches because of the force of the robot. So it's a bit a more thicker thread than we would use in open surgery when we suture a gastrojejunal anastomosis, for example, in open surgery. And we also do the anterior wall with a running suture hands-on. This is a third thread. We use like a 22 centimeter length thread and do the knotting intracorporally, of course, because it's easier with the robot than laparoscopically. And you see here the end of the anterior wall, the running suture of the anterior wall, which is then ended with another stitch, which was just prepared at the angle of the anterior wall. And this ends the gastrojejunal anastomosis. We now have an omega, which will be transformed in a Roux and Y later. We measure 150 centimeters We estimate by the robot 150 centimeters of alimentary limb, and do then perform also the jejunal anastomosis by hand suture. Many surgeons do this by the stapling device with like very good results and very low leak rates. We just do it because we have the robot here, and it makes us also save a little bit of money, so we don't need stapling devices for the jejunal anastomosis, and we end the operation with the closure of the mesenteric defect. The final pathology specimen showed a gastritis again, and it showed 2 more intestinal metaplasia spots, not only in the antrum but also in the corpus. We can see here the EST site, which the patient had before, with the pylorus here. So I conclude that patients with intestinal metaplasia have a risk for adenocarcinoma. The high-definition endoscopy with chromoendoscopy is recommended, and the biopsies should be taken, as we said, at least at 5 localizations. The no surveillance is recommended for mild to moderate atrophy, restricted only to the antrum. Patients with single intestinal metaplasia but positive history, family history, or incomplete diagnosis, or Helicobacter pylori gastritis should get into a surveillance program. The advanced stages of intestinal metaplasia should get into surveillance program, and the low-grade dysplasia, if you already have a dysplasia, and which cannot be seen and cannot be resected, surveillance is necessary after 12 months, and high grade after 6 months. The patients who have visible lesions should get lower high-grade dysplasia should undergo staging and treatment. So thank you very much. I close with the picture of my whole team, and we have Professor Stefan Mönig, Christian Toso, the chief in Geneva, and I also have Woo-Jin Yang, who was my mentor in Korea, who we invited to Geneva for our first robotic oncologic gastric surgery. Thank you very much.
Thank you very much, Minoa, for this very nice presentation, also nice video on the technique. Maybe before we start the discussion, one has to ask, what is the proper or the possible approach to that? Definitely good that he worked in your hospital and the patient came for a second opinion to your house. I think there are many factors involved. The GERD, if you didn't have GERD, a sleeve could have been a possibility, so you keep the possible access for surveillance. If you go for a bypass, then you must resect the remnant. And if you did not resect the remnant, I think you do a big mistake. And for some patients and also for some referring physicians, to take out this precancerous lesion is very aggressive, but this is very individual. We have patients done that in similar cases because they were so much afraid. They had family members dying of cancer, so they support an aggressive approach. So these are the 2 options, but definitely not a regular bypass with leaving the remnant without endoscopic access. Are there any questions from the... Beat, any remark from your side?
No, again, I completely agree. It was a perfect survey on the topic. Thank you very much. And I think he would have done the same. I'm happy that you, Ralph, also said that a sleeve gastrectomy also could be an option. In this case, I always say to have a Barrett esophagus is not a risk per se. So what I mean is to have a Barrett esophagus means that you are in a good surveillance program. And if you really develop dysplasia, you can do an ESD later. So it must not be a risk for cancer at the esophagus if you have a Barrett. You are muted, Ralph.
We do have to admit in this audience that if we do sleeves and have Barrett's and they do develop into Barrett esophageal cancer or adenocarcinoma, we have a difficult situation for reconstruction. I mean, we do not have a sleeve for Ivor Lewis reconstruction, and all the colonic interpositions are not as good. So I think this is something we'll have to look down the road. France is doing a lot of sleeves. United States now does a lot of sleeves. Middle East does so many sleeves. So I really wonder 20 years from now what we will see. Maybe you guys will be happy to do all these esophageal cancers, but tell me what you're going to do for reconstruction.
The point which I wanted to make is that if you have Barrett, the risk for development of cancer is very low. And you are in a surveillance program. This means if you develop dysplasia, you can resect the Barrett by endoscopic means. So what I mean is, I'm not sure that the problem of developing esophageal cancer is increasing with the increase of Barrett's esophagus after sleeve. I hope you can understand what I mean. You are in a surveillance program, and this is also protective. There are other studies in reflux surgery, for example, published several years ago, that if you are randomized in the group of patients with PPIs compared to laparoscopic fundoplication, the risk of mortality is higher after about 20 years. And the explanations of the authors, it was a study by Landell, was that if you feel better, you are not in a good surveillance program by your general practitioner. Do you understand what I mean? If you have a problem and you get into a surveillance program, it's also in a kind protective for developing a fatal disease.
Yes, I do agree with that, but not everybody follows the endoscopies, so we will miss a lot or some. And second, the progression rate from Barrett into cancer can be as high as 2% per year. So, I mean, you must correct me, guys, but I mean, there is an elevated risk. And if they don't follow the surveillance program, then we will see more cancers. I mean, that is for sure that we will see that 20 years down the road. Reflux is acidity in the esophagus is not something you want to have lifelong. And if we operate 20-year-old ladies or girls or whatever, and then they have an expectancy of life until 79, then we will see that eventually. So I'm not saying I'm not against or for sleeve, but I think we just have to be cautious. But what do you do if you have adenocarcinoma that you cannot, not superficially, not resectable by endoscopy, that you have to do resection? I mean, then the options are not as good as they are today. Are there any comments on that? No? don't want to say anything.
Stefan, I still, you know, we discussed many times. I discussed these cases also with Stefan Münig, because I'm also worried about creating future Barrett patients where we cannot do the standard Ivor Lewis reconstruction, and we did not. We have to use other organs for the reconstruction. And for the moment, I think the experience here in Geneva, I have not had for the moment a patient who developed adenocarcinoma after sleeve gastrectomy who needed an esophagectomy. But I don't know what you think, Stefan. What reconstruction would you suggest in that case, when the stomach is not usable anymore. You have the whole arcade isn't there anymore. It has been fully resected. You have like 4 or 6 centimeters, and then it's the pylorus and no vascularization of the greater curvature anymore.
So I think it's very clear if it is ZVAD 1 and you have to do an esophagectomy, subtotal esophagectomy, then it's probably the only possibility for European patients. It is coloplasty. If it is a ZVAD 2, probably then it's possible to do a transhiatal extended resection and the reconstruction with the small ball. This is in some cases possible. We have done it if the stomach was not there, and then we have done a thoracoscopic approach or a thoracotomy approach if the anatomy of the small ball is so that you can bring it in the thorax. But it is a problem, clearly, and what Ralph Peterli said is correct. We don't know what's going on with these sleeve patients, and if they are operated in many countries with 20, 23, 25 years, and they have a life expectancy of 80 years and more. What's going on? This is a special question, and I think the reflux is much higher than with the patient who is developing with 40 or 45 years hiatal hernia.
May I have an alternative reconstruction possibility. My boss, Markus von Flü, he did quite a number of research on the ileocecal ileocecum as a replacement for rectal cancer, and we do use it in esophageal cancer in patients that have a very bad stomach. You cannot use it, or the colon has been resected already, where you don't really have any option for the transverse colon. Then the ileocecum can work fine, but obviously it's a difficult, challenging operation, but it is a valuable alternative. Yep. And you also have a valve that protects maybe some reflux. Are there other comments?
Yes, maybe I think this is maybe not a very common surgery here in Germany. No. And I would not take it as an option. This has to be evaluated, I think, in future. But I think it's possible to do it in certain cases. You know, I think it's a good idea to use it. There's a valve, but I don't know of a really large series to show that it's adequate next to a standardized colonic in a position or so. If the colon is not there, or yeah.
Peter, you're one of your teachers, Paul Schneider.
I know.
You know him very well.
He's a fan.
He's our very good friend, and we have done many, not only operations together. And he has done some cases in Zurich.
Yeah, we talk of some cases. That's the point.
That's all I say.
But these are special indications, and it is really a possibility.
Well, I've done one. I understood that the question is if we get these patients after sleeve in coming up to hundreds in a series, not in one out of in 10 years. I think we are expecting maybe several per year in future. Maybe are you not talking about these, or are you talking about the extraordinary cases? Because we have also after a Whipple operation adenocarcinoma of the esophagus, and this is always like cases which are unique or are very rare. But I think what we are afraid of that we will expect a percentage of patients with adenocarcinoma of the esophagus after sleeve.
I fully agree this will be increased, and that ileocecum is just for very rare cases. But I mean, it's nice to have that as an alternative. So just to think
it's
of
one option more.
Yeah. But
Maybe
Other comments, yes?
another point on this sphere is that, I mean, these patients need a surveillance. These patients are on PPI. These patients are, I mean, they are in a different circumstance maybe, yeah, or should be. And this makes it a different, maybe a different strategy already necessary. Endoscopic resections are arising and have more and more possibilities. So I think maybe we have fear of something coming, but maybe it's already, the power of this impact is taken out by endoscopy and surveillance already. Maybe, I don't know.
But maybe, yes, Beat, go ahead.
I just wanted to thank Peter for this comment, because this is what I wanted to say.
Mike, I don't hear your mic. You must turn on your mic again.
I hope you could hear. I just thanked Peter for this comment, because it is what I tried to say. Go ahead, Ralph. You wanted to say.
Yeah, but I forgot it. I didn't sleep last night. I'm sorry. So I forgot what I wanted to say. But
the point I wanted to make is that these patients have to get an endoscopy, and then they go in a surveillance program when they have a Barrett. And this is a criteria of safety and security when you are in a surveillance program to not develop cancer.
What is your experience with bariatric patients for the surveillance? Is it difficult? Because of many of these patients are not very, this is the reason why they are so obese, or one of the reasons.
Yes. I agree with you. This is the problem when you are talking about nutrients and something like that. But if you tell the patient that he has a risk of getting cancer, and this is what we know from reflux patients, they go into the endoscopy program because they fear the cancer. And again, this is what makes me saying, or trying to say, that it is also a criteria of safety to be at risk.
Beat, we fully understand this, but we are talking about disciplines, Germans and Swiss. They are there. If you tell them go and do an endoscopy, they show up and they do everything. But I mean, we talk about the vast majority throughout the world where they don't even get access to an endoscopy before surgery. They operate on patients with cancer and realizing it during surgery. I mean, we discovered 4 cancers in our pre-op workup, so we could treat them first. So I'm talking about the big picture in the world, and they won't be accepting this surveillance program because they will never have an endoscopy. So I think talking about Germany, university, maybe in France, I can't judge how much they like endoscopies, the patients, but obviously if you tell them there's a risk of cancer, then they will show up. Now, what I remember now, what I wanted to say before is, I mean, obese patients are at higher risk for any kind of cancers. So this risk does not necessarily be reduced with the surgery right away. So they continue to be at higher risk for cancer development. So they will be followed or surveyed not only for esophageal cancer, but for all sorts of cancers. So I think we in our world can do that, but others maybe not. So that maybe is a second thought. So,
Christian, good show. Welcome. What do you think about that?
Thank you. I was not able to follow everything, the whole session, but I fully agree with the concerns regarding the sleeve gastrectomy in terms of future incidences of esophageal cancer, and also the difficulties for the surgeons, for us surgeons, to perform a proper reconstruction to allow those people to have a good quality of life afterwards and a good oncological outcome. And I fully agree, and I really don't have a substantial remark to do regarding the cancer risk. I fully agree with that. I would not advise to do sleeve gastrectomy. I have another question, maybe 2 questions. Sometimes we see sleeve gastrectomy patients with not Barrett's, but debilitating reflux and not and they don't want to have a bypass for what reason ever. Would you consider to do something like a magnetic sphincter augmentation in such a patient if he really does not want to have a bypass procedure? This is one thing. And the other, the mini bypass is also an emerging technique in bariatrics. And as far as I have learned, for Barrett's esophagus to develop, you need a mixture of acid and bile reflux somehow. This has been a theory that has never been totally proven, but it's a theory. And so the mini bypass, in my eyes, could be increased risk, maybe even more compared with the sleeve gastrectomy. But I'm not familiar with the literature, and I don't know data on that. And and a third question, maybe on to Ralph. You didn't see any dysplasia in your Barrett's patients, no?
No, in these series, we did not see any dysplasia. To get back to your questions, number 1 and 2. So number 1 is, if you have a hiatal hernia, you can fix it. I don't believe in these magnetic rings or whatever, no foreign bodies. I have taken them out everywhere, like the angle-check prosthesis. So I do not believe in that. If you have reflux, it can also be due to a stricture or a torsion of the sleeve. So you may be able to resect this middle part of the sleeve and make a gastrogastostomy, or you can make a seromyotomy, but there are other ways. And if patients, as a first step, they can go through a fixing the hiatal hernia and reflux. But if this doesn't work, then I think they have to be convinced to be converted to a bypass. And the second question, I mean, there are animal models by Jean-Marc Chevalier in Paris for the omega loop gastric bypass. Please don't say mini bypass. There's nothing mini about it. It's a malabsorptive procedure. It's dangerous. In many ways, it's not a standard procedure in the United States. We, the Swiss, did not accept it as a standard procedure yet. There has to be more data. There's very conflicting data, not very good quality trials so far. The French trial had more severe adverse events in the omega loop bypass compared to the regular bypass. So we will have increased risk, but it has not been proven yet. So in the animal model by Jean-Marc Chevalier, he could not demonstrate it, but I don't know the model exactly, whether that was a solid model for proving that omega loop gastric bypass does not increase the risk of cancer. So, I mean, that is another thing we have to follow down the road, the more that these procedures are being performed. Any other comment or answers to Christian's questions?
I'm not really convinced with your solution towards reflux disease in sleeve gastrectomy, because hiatal hernia is not always the problem. You have no fundus left, which is an important part of the natural or the anatomical anti-reflux valve. And so I fully agree that there you might also have some sand. We klingt Sanduhr,
strictures, yes.
Stricture in the so even if you perform hyatoplasty, this might not be enough. And anyway, but
No, I'm not saying it's enough. I mean, there also means that you can do some kind of a valve. There are a lot of operation technique off the sleeve. Or then there is the Nissen sleeve by David Nocker. He primarily makes a sleeve, and underneath he makes a sleeve. Nissen fundoplication, underneath he makes a sleeve to prevent it. But these results, they're not. There are some good results he demonstrated, but for the time being, this is still experimental, in my opinion. But if you have a patient with sleeve, I'm saying that many of them have a hiatal hernia, and many of them have a problem further down. It can be solved, but usually they accept to be converted to a bypass. Stefan, is it up to you to close, or?
Yeah, I think so. If there are no other questions, comments, Then I would say thank you to all. It was a very interesting discussion about tumors, about bariatric surgery. I've learned some things, and I was very happy that even some or many surgeons from Switzerland are there, and I hope we can continue this. And for the future, probably it's possible that we have something like that from Basel or from Zurich. We can discuss this, or from Heidelberg or from Mainz. And I wish you.
Je peux dire quelque chose, Frédéric, si tu veux. Là.
And I wish you a good time, bon Noël, and stay healthy, because of the third wave will come. And it is, in Geneva, now we have a little bit reduced the number of cases, but it is really terrible.
Thank you, Stefan. Robert, do you want to close the session?
Well, very, very, very briefly, it was a friendly, most interesting session with various problems discussed about the rare tumor, about the problems of the Barrett's esophagus that may occur in patients with after some types of surgery, like the various types that were discussed very interestingly in the various statistics. What I wanted to tell you is that now the OESO-SEMPIRE platform has another direction with the discussion of these clinical cases that will be organized every 4 to 6 weeks in the near future. And it comprises now 15 pilot centers. And I wish to emphasize that the pilot center in Geneva will take a major role in our project in the near future, and more precisely in the OESO-SEMPIRE that we organize with the Stanford School of Medicine in the Train the Trainers program, which could benefit from the presence in Geneva of the Swiss Foundation for Innovation and Training in Surgery. And I think we'll have to speak about this with Stefan, with the team in Geneva and the other teams in Switzerland, to know how we can expand the broad project of the OESO-SEMPIRE platform, especially now in the aim of using these kind of discussions for the content of the next OESO Congress, which cannot be at this moment precisely stated in the calendar. In one word, I wish to express my thanks and hearty compliments to Stefan Monique, to his team, to the members of the panel for this great presentation that we enjoyed today and that we will bring back home, each of us. Thank you for being here today, and very nice Christmas and holiday season to everyone.